All right, good afternoon, everyone. Welcome to the webinar. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. Thank you so much for joining us today for the Rural Health Clinic Cost Reporting 101 webinar. LRHA is happy to host this webinar presented by Healthcare Business Specialists as the first of a two-part series. This webinar will cover the basics of RHC cost reporting, and our next webinar will cover some more advanced RHC cost reporting information and will be held next week on the 15th. I will post the link in the chat to register for that webinar if you haven't already. This webinar is being recorded and will be available along with a copy of the slides on the education page of our website, and I will drop a direct link to the relevant page in the chat as well. Your line should be muted. Should have been muted automatically when you joined. Please remain on mute to prevent background noise, and you can enter any questions you might have in the Q&A box. After the webinar, a survey should automatically open in your internet browser. We do ask that you please complete that survey as it helps us to continue to improve our future events and identify future education topics that would be valuable to you. So with that, I would like to welcome Mark Lynn. Mark has served since 1989 as the President of Healthcare Business Specialists, a healthcare consulting firm based in Chattanooga, Tennessee. Mr. Lynn is trained as a certified public accountant and is also a certified rural health clinic professional, a certified cost report specialist. In his role at HBS, Mr. Lynn helps prepare Medicare and Medicaid cost reporting for RHCs. He helps physician, nurse practitioner, and physician assistant practices become certified as RHCs, works with RHCs in developing and implementing emergency preparedness plans in compliance with conditions of participation, conducts program evaluations for compliance with conditions of participation, and works with RHCs to report and disperse COVID-19 provider relief funds in accordance with HHS guidance. Mr. Lynn is a frequent speaker at national and state meetings regarding rural health clinic matters. So we're so thankful to have Mark here today, and I'm going to go ahead and hand it off to you.
Okay. Hi, Danae. Thank you very much. I appreciate it and appreciate our folks in Louisiana for all the things that you do for healthcare in your community. There is my contact information if you need to get in contact with me in regards to cost reporting or any of the questions that you may have about this presentation. Again, the disclaimer is I've updated everything as of today, but all situations are different. Do get in touch with your cost report preparer if you plan on making any changes based upon this information that is presented to you today. The objectives is to just give you a general understanding of cost reporting and go into some of the building blocks of how your cost report works. We're not going to show you how to prepare a Medicare cost report, so you're not going to come out of these two hours and be able to take my job, although I'd like to give it to a lot of people. But so that's the general objectives there. Some of the things we'll talk about is just the expenses, what's allowable expenses, what's not, how to count visits. That's getting more and more complex, and productivity standards in rural health clinics, flu and pneumococcal reimbursement, and then how you can get paid for your Medicare bad debts. I will stop the session after 50 minutes, and we'll have about 10 minutes of time for you guys to ask questions, and I'll respond to those. So the overview, first thing before we get into the cost reporting, there's two types of rural health clinics. There's independent RHCs. Those can be owned by anybody, physicians, nurse practitioners, non-hospital companies, things like Fast Pace or urgent care companies. A lot of those own rural health clinics. And hospitals, typically hospitals with more 50 beds or more, they would own independent RHCs. The second type is what's called a provider-based RHC, and those are owned by hospitals. Typically, they would be with less than 50 beds because at one time there was an unlimited cap on those provider-based RHCs. Those days are gone with something called the Consolidated Appropriations Act of 2021. But there are still provider-based RHCs out there. If you became a provider-based RHC before in 2020 and before, they are grandfathered, and they have a site-specific, all-inclusive rate that's a cap for them. All other RHCs have what's called a national statutory payment limit. That applies to independent RHCs, and that applies to all RHCs that were certified in 2021 and going forward. So those are the two types of RHCs. And then here is the language in the Consolidated Appropriations Act regarding independent and provider-based RHCs. The key to remember is if you had a provider-based RHC December 31st, 2020 and before, you are grandfathered. You don't have to worry about those national statutory limits, but you will have an individual rate set that will limit your growth of your cost per visit. So you'll want to watch that very closely, because you now are subject to a cap. All RHCs are subject to a cap. This piece just came out. It's actually in MedLearn Matters today. It came out in the newsletter that Medicare sent out today, and it's a 3-pager. The link here is right here. It just shows the limit for the national statutory limit for independent RHCs and provider-based RHCs in a hospital with 50 or more beds is $126 next year. Your specific grandfathered provider-based RHCs, your cost per visit can go up by 3.8% is what this is telling you as well. So that's some important news for you. The Consolidated Appropriation Act really is a game changer in as far as cost reporting goes, because the caps before were so far below your actual cost per visit that your cost report really had very little impact on your operations, because you were going to get above the cap. Now we're all the way up to $126 a visit, and a lot of our clinics will not have a cost per visit near $126 per visit. So you will actually be getting less than this cap, and it goes all the way up to $190 in 2028. At that point, it stops going up by $13 a visit and goes up by the Medicare Economic Index. So keep that in mind as these rates are going up. So you do have some room in your if you have a lot of Medicare utilization to really to put services through your rural health clinic and get compensated for it. Do remember, when I say it's an all-inclusive rate, it's not really an all-inclusive rate, because the AR does not cover lab services, including the 6 required lab tests. Those are not a part of the all-inclusive rate. Your technical components on maybe your X-ray or your EKG, those you can bill and get paid either fee for service, or if you're a CAW, you'll get cost-based reimbursement for that. But it's outside the RHC rate. Your chronic care management services are not paid under this all-inclusive rate. And your telehealth services, except for mental health services starting in 2022, those are a part of the all-inclusive rate, but your actual sick visit, maybe somebody calling you up, or you're doing telehealth for maybe COVID, that would be, there's a fee for service that you get paid for that. Also, hospital services have always been excluded from this rate, so you're going to be billing that fee for service. Typically, it's billed on a 1500 form as well. So getting on to the actual cost report. What is the cost report? It depends on if you're independent or provider-based. If you're independent, you're going to do a Form 222, very simple, maybe 8 or 9 pages at the most. Not hard at all. Even somebody as dumb as me can do those very easily. And then there's a Form 255210. That is a hospital cost report. It is hundreds of pages long, very complex. But the good news for our RHCs is you have to provide basically the same information. It's just the M series of that hospital cost report is what you guys are responsible for as far as RHCs. The cost report covers a 12-month period of time. However, it could be different periods of time if once you become initially surveyed as a rural health clinic, Maybe you got surveyed on September the 1st and you're a calendar year in, your cost report will run from September 1 through December 31st. Maybe if you were certified on December the 1st of the year, you could actually ask Medicare for up to a 13-month cost report, and you could file that one cost report instead of just having a 1-month cost report. You would just file a 1-month cost report, and then another 12-month cost report. You would have one cost report for 13 months. 13 months is the longest period of time that you can have for a Medicare cost report. The purpose of the cost report is to settle up with you. Think about your tax return that you do every year. I know the tax return is a dry subject, as is the cost reporting. So it is something you have to do. If you do not do this, Medicare will not pay you. They will cut off your payments, and they will ask for every penny that they paid you during that fiscal year. So if you receive $200,000 or $300,000 worth of Medicare monies during the year, and you think, well, I'm just not going to do this cost report, Medicare will actually put a lien on you. I've seen them do this before, a lien on your money, and they'll want every penny they paid you back during the year. So you will have to file a cost report. Governmental agencies also require or use this information to set healthcare policy. Maybe that 3.8% comes from some of the numbers they generate from this as far as a Medicare Economic Index. And then Medicaid in most $418.19. So quite a range there. And as far as that, but that's not based upon your actual cost. It's based upon your location is what Medicaid is, the way Medicaid does that. And if your services change, your visits change, there is a scope of practice change that you can get. So you may want to look at that. If you're on the low side here of the $84.78 or the $99.42, there may be a scope of practice change that you could get to reset your rate. Also, for provider-based RHCs, there is an option where you could get 110% of your cost per visit. So you may want to look at that as well. And again, you'll want to talk to your cost report preparer on anything like that as far as that goes. Here's a couple of things that I think I've covered most of this, why the cost report is important. You will receive settlements for flu, pneumococcal, Medicare bad debts, preventive copays and deductibles, and there will be a difference in your rate settlements. And the rate settlements are, because the rates are going up by $13 a year, those numbers can really fluctuate. In the past, the rates that we have, the settlements on the cost report have been generally very, very small. Nowadays, you could end up owing back a bunch of money to Medicare, or they could owe you a bunch of money, because if you've got 10,000 visits and the rate increases by $13 a visit, I mean, you know, that what is it, $130,000, $140,000 that you could receive as a settlement. Likewise, if they were paying you $113 and your cost only came in at $100, then you may be owing back, you know, $40,000, $50,000, $60,000. So the numbers are getting much bigger on these settlements just because these caps are going up. You're also responsible for preparing the cost report accurately. That's why we tend to do a lot of education with our clients to make sure they understand the rules. It's no fun when I've had the FBI walk in here and give me a subpoena and ask for information, and it's no fun. So you definitely want to you'll want to make sure that you're following all the rules. And that wasn't for something we did wrong. That was something the client didn't keep good records. So keep good records is what I would tell you there. So what does Medicare settle on the cost report? Again, the difference between the interim and final rate, your Medicare bad debts. And we'll talk more about that at the very end of the session. Flu and pneumococcal, COVID vaccines, and monoclonal antibodies. If you're still giving those, those are settled up on the cost report. This is now for original Medicare only, not Medicare Advantage. So don't get confused, because in 2021, there was some Medicare Advantage COVID vaccines on there and MABs, but that's no longer the case going forward. And then graduate medical education. If you guys do have a GME program, there's a direct pass-through for those costs on the cost report. So you'll want to make sure you keep up with those costs and claim those, because that is additional reimbursement that you can receive. Here are the forms that you need for an independent RHC. It's the CMS 22217. There's a link to the 95 pages of instructions on how to complete it, and there's a link to the vendors that are approved. You're going to need some outside software in order to do this. We use HFS, which is great. All the cost report preparers that I know use HFS. There's also another one that's I think it's Pete Marwick has one as well that some people use. There's only two for hospital cost reports as well as RHC. So those are the ones you can use. You do have to file this electronically. Nowadays, what we recommend is using MCRF. MCRF is something that Medicare has set up where you can file your cost report electronically, and it's very smooth. It's very easy. What you want to do is get your cost report preparer set up in something called IDM, the Identity Management System of Medicare, and make that person your authorized cost report preparer, and they can submit that report to you electronically. That's going to speed up your processing of your cost report dramatically. And then here's the different forms that you have for the independent RHC. You can see there's like basically about nine or so different forms that we have to fill out. For provider base, they have the same exact information for the most part, except for you're going to have to come up with some statistics for your provider-based RHC, because there's what's called a step-down allocation of expenses from your general cost centers, and it will allocate parent overhead to your clinic. You want to capture those statistics the best you can, because that's going to put more money in your RHC's pocket if you do those statistics correctly. So you'll want to look for, I think it's B-1 is where those statistics go. So when you're the cost report person asks you for statistics, take those seriously, because they can really help you get more reimbursement for your clinic. Here are the timelines. You have 5 months from the end of your fiscal year in order to file your cost report. So you have a 12/31 year end, it's going to be due May the 31st. The MAC is called the Medicare Administrative Contractor. For Louisiana, most of you guys will be using Novitas will be your MAC. So you'll want to keep up. You want to follow that MAC and find out any information you can from cost reporting. You also want to make sure you pick the right jurisdiction, because Novitas has not only the Louisiana area, but it has also a Pittsburgh contract, or somewhere up in the east where they have one. So just make sure you get the right contract when you're looking up information and you're faxing. I know a lot of people fax that credit balance report every quarter, and it's very easy to get the wrong Novitas MAC and fax it to the wrong number. So always double check those the MAC and make sure you get the right contract for Novitas as well. So they'll have 30 days to settle up to accept your cost report, and then another 60 days to get you a tentative settlement out if it's reasonable for them to pay that. And then they have 1 year to settle up the cost for what's called an NPR, Notice of Proposed Reimbursement, and final settle with you. The great thing about that MCRF is if you do this, if you file it electronically, usually within a week or two, all these steps are done. I mean, it is really, really amazing how quick they can get these things done. So going into building blocks, how do you compute your RHC all-inclusive rate? And I was something earlier that it was so easy when I started doing this. You just take your total expenses, you divide it by your total visits, and we knew what our cost per visit is. That's not the case now. It's sort of become polluted with all sorts of what we call fee-for-service items on here. So now the formula is total allowable RHC all-inclusive rate cost minus your fluid pneumococcal cost. Divide that by your RHC all-inclusive rate visits. And that includes all payer types. One of the big mistakes we see is people over counting their payers. But what we want you to do for your total visits is count all of your visits from Medicare, Medicaid, self-pay, no pay. The way the cost report works is it does take your total allowable all-inclusive rate cost divided by your total all-inclusive rate visits. So you'll want to count all those payers in there. And now that rate is limited to the cost per visit cap, which is these national statutory limits. Again, they've increased dramatically. So this is a great thing for RHCs. Allowable cost, reasonable and necessary, that makes sense. Physician compensation, nurse practitioner compensation, PA compensation, you'll want to make sure you pay everybody well. Overhead, equipment space, supplies, those sort of things that are required for providing services to your patient. As long as they're reasonable, that's going to be an allowable expense on the cost report. We use the provider reimbursement manual. We call it the HIM-15 manual to determine if things are allowable or not. And so first thing question I always get is there a list of allowable expenses for the cost report? And unfortunately, the answer is no. And the reason why is this HIM-15 manual is thousands of pages long. And so you go through here, here is the listing here of the different chapters. What happens is when you click these links, you'll go in, it'll actually download a Word file, and that Word file may be 10 pages long, or it may be hundreds of pages long. So trying to get just a comprehensive list from that, nobody's done it yet. Maybe when I retire, that'll be something I'll sort of go back and try to do. But as right now, ain't nobody got time to make a comprehensive list of those expenses. Next question is, are all the expenses of the clinic included in the all-inclusive rate total cost? And the answer again is no. There are services that are paid on a fee-for-service from Medicare that you will not include that cost in that computation. Things like laboratory, remember those things that are paid outside the all-inclusive rate that I explained to you earlier? So the lab, including the 6 required lab tests, you'll want to keep up with, in one of your general ledger accounts, keep up with your lab supplies, how much you paid for reagents, how much you paid for CLIA and COLA and all the different things. Have a salary place for your lab tech there, and keep up with those expenses. Same things with your technical components, your EKGs, your technical components of your x-ray. We will want to disallow that cost on the cost report as well. The time your physicians spend over at the hospital, we're going to disallow that. Telehealth, except for mental health, that cost is going to be disallowed as well, as far as computing your computing your all-inclusive rate. Chronic care management, if you've got ChartSpan or one of the CCM vendors doing chronic care management, those types of fees and those types of expenses are going to be excluded because they're paid on a fee-for-service basis. So those are the expenses that we disallowed right here. Likewise, when we start counting our visits, we want to count only the visits that we counted the cost for. So here's what our denominator in this process is. Number one is you're not going to count 99211 visits, the ones that should be a nurse only visit. That doesn't qualify as an RHC visit because I'll give you a definition of what a visit is just in a second. It's not going to meet that definition. And lab procedures, injections, hospital visits, all these things I just described to you, don't count those visits or those procedures as a part of your counts. Also, be careful. In Louisiana, when you bill Medicaid, y'all use a T1015 code. You also use a CPT code, a 99212, 99213. Do not double count that. That T1015, if you count all those and you count your 99213s and 99214s, you are going to be double counting your total visits. And I know that makes you feel real good that your visit counts are super high. I'm highly productive, but you're only getting paid for one of those. You're not getting paid for the 99213 and the T1015 from Medicaid. You're getting paid for one of those, and you are double counting your visits if you do that. That may not have affected you in the past, but when these caps are going up substantially higher, you are going to hurt your reimbursement rate. You're going to lose thousands and thousands of Medicare dollars if you don't correctly count those. So in counting, you're come in with your visit counts for your all-inclusive rate. Again, Medicaid, we just talked about that. Is it included in the cost report as a visit? Yes. Is it allowable Medicare in this case, Medicaid, allowable cost? Yes, but you only count one visit. For a telehealth visit, and this is again for a sick visit, you've got a CPT code of 99213. When we bill, unfortunately, we bill it as a G2025. So you don't want to double count these G2025s either. We're going to get paid fee for service for that. And we actually are not going to count this on the cost report as a visit that we include in the all-inclusive rate. So keep that in mind. Also, you need to check with your Medicaid rules in Louisiana, how they pay for telehealth visits. If they pay at the all-inclusive rate, then they should be included for the Medicaid cost report, but not the Medicare. So again, another level of complexity. Medicare and Medicaid have different rules that you sort of have to deal with. Mental health services, yes, starting in 2022, that is an all-inclusive rate from Medicare. So you're going to include that cost on the cost report, and we're going to count that visit on the cost report. Virtual communications, another sort of telehealth service, you're going to disallow, you're not going to count that visit, and you're going to exclude that cost on the cost report. And then coming down to your chronic care management, then there's the G0511 code. We are not going to count those visits on the cost report, and we're not going to include the allowable cost on the cost report. So keep up with that cost so we can exclude it on the cost report. That's going to be important that you do that. So again, not very easy anymore. Used to be pretty straightforward, not simple at all in order to get these counts correctly. Definition of an RHC visit. Four things have to happen. Number one, has to be medically necessary. Number two is it has to be a face-to-face encounter or via telehealth for a mental health service. One-to-one encounter. No groups. I always tell people no groups. And what was the other one? There's another one, no groups and no globals. No, there's two G's, no groups and no globals in rural health clinic billing. So must be medically necessary, must be a face-to-face, must be within the practitioner's state scope of practice, and must require the skill level of that particular provider. And what that means is if you got a physician, they can't just run in there and start giving allergy shots, say, well, I'm going to meet all these criteria. The first three criteria, you'd be fine. But the fourth one, it doesn't take an MD to be giving an allergy shot or giving a flu or pneumococcal shot. A nurse could certainly do that. And so if that's the only service they're getting, you don't want that would be, it wouldn't be fraud, but it would be an abuse. So you would not want to do that. So what we ask for is a CPT frequency report by provider. That's what most cost report preparers ask for when they're doing a cost report, because that's the cleanest way to get our visits. Don't write it down. I've got some doctors that they got a sheet. I've got a little sheet of paper where I was taking notes, and they'll write down on the little sheet of paper what their visits were. That's not any good. That's when the FBI shows up at my house and says, how'd you get this number? I was like, here, this little piece of paper is what they gave to me. And they said, can I have that piece of paper? And I'm like, it's all yours. You can. So we need good records in order to count your visits correctly. I'm not going to go over this table, but this is going to help you determine where to put each one of these visits. Counting visits is more of an art than a science. Now, we try to make it a science, but as of right this moment, we haven't got it down to a science yet. And then there's the rule on mental health visits for 2022 that's paid at the all-inclusive rate done via telehealth. So keep those rules in mind. That is a change that we want you to be aware about. Question: why is a CPT report by payer not the best way to count visits for the RHC all-inclusive rate? Because I get people all the time, they want to send me the payer mix, and what that does, that makes me have to count all your Medicare, your Medicaid, your Amerigroup, your United Group, your Emeritus, all the different groups that you have. We have to go in and count those, and the problem is sometimes the patient will have a primary insurance and a secondary insurance, and they're gonna end up on that report 2 times. That's going to double count your visits. You know, the worst thing that you can do is overcount your visits. So you don't want to overcount your visits, because that's going to kill your reimbursement rate. So the cleanest thing, the simplest thing is to get a CPT frequency report, have it be a summary, shouldn't be over 6 or 7 pages. When people send me these reports that have 590 pages, the first thing I do is I'll text or email them back and say, hey, I ain't counting 590 pages of your visits. You got a computer that will do that. And so, and that's, I'll go back and ask for that CPT frequency report. Okay, let's go back into expenses. Now, we talked about visits a little bit. We sort of jumped past allowable expense. So what you need to submit to whoever's doing your cost report is some type of financial statement, a trial balance, a profit and loss statement, a tax return. That's sort of the last resort, because you're supposed to do your accounting in accrual basis. And typically tax returns are done on a cash basis or a modified cash basis. And we will use it if it's either that or nothing, but I would rather have a P&L statement that's prepared on a accrual basis. That's what Medicare is looking for in order to do these cost reports. If you're provider-based, you probably have some type of departmental summary report that will be very helpful to you, some type of internal financial statements, and even you may even have audited financials, and that would be great if you can provide that. For independent RHCs, you're not going to have audited financials unless you ended up with more than $750,000 worth of grant funds that had to go through a single audit. There may be a few nowadays that actually have to get an audit. But for the most part, rural health clinics will not have audited financials. Typically, you're going to have QuickBooks, and you need to have a good chart of accounts that sort of lines up with the rural health clinic cost report as well. And the way the cost report works is there's 3 different sections. I think of it like a red light, like a traffic light. The green area, let's go. We want to put as much cost as we can in lines 1 through 39 of the independent cost report. That's your healthcare cost, it's staffing, and there's a few other costs besides staffing in there as well. Your facility overhead is lines 40 through 74, and your cost other than RHC services or non-reimbursable service. That's the red area. We want that number to be as low as possible. That's line 75 through 100. So let's take a look and see what that looks like. I was working on a cost report this morning, and I just shared the screen here from this. This is healthcare cost lines 1 through 39. You can see the salaries for our physicians, nurse practitioners, PAs, clinical psychologists, social worker, lab person, nursing salaries. All of this is listed here. And then medical supplies, transportation for healthcare staff here, depreciation, malpractice, those sort of things are listed. These are related to providing healthcare for your patients. And notice lines 30 and 31, pneumococcal and influenza vaccines. You'll want to, in your general ledger, set up separate accounts and capture that information so we can put this on the cost report directly. So I want to make sure we do that. And the next one is facility overhead. Things like rent, insurance, utilities, accounting, the cost report prepare, it's going to go in that number. Fringe benefits, billing services, those sort of things will go in there. We noticed that we did have some non-allowable expenses in here as well. Those are things like advertising, liquor, trips to Bermuda, all those sort of things that Medicare has no business in paying a portion of. We're going to disallow that and adjust it out of the cost report, so the allowable expense is 0. And then cost other than RHC services, these are what we've been talking about here. Your telehealth here, we had $326 worth of that. Your chronic care management was $9,254 of that. We're going to disallow that. Your hospital services, in this case here, we had $1,623. Our lab, we paid 20 grand for lab services. X-ray, we didn't have any of that. And so one thing that you do want to remember too is if you have an outside contract, somebody doing the CCM services and they're doing it offsite, they're really not pulling overhead. So you'll want to make an adjustment for that and disallow that. So if this was an outside company, I would actually make an adjustment for, and that was the fee we paid them was $9,254. I would disallow that expense on the cost report. That way it would not pull overhead. And so our next calculation here will show you why that would help us. What happens is the cost report, it takes that green cost, that $311,954, and that red cost that we just showed you of $40,285, and it adds those together. And what happens is it makes a ratio. We have $311,000 of RHC cost out of $351. That's 88%. So we're going to take our yellow overhead, $480 grand, and that's a problem with healthcare these days. Is that overhead is actually more than the medical services that we're providing to the patient because we have such an administrative burden. It's a different story. But in this case here, we have 480,000 of overhead. So multiply 480 times 88%. That's going to be how much allowable overhead we have, 425,000. And we're going to add that to the 311. That's going to give us 737,000 of allowable RHC costs for our all-inclusive rate calculation. You didn't know there's going to be a lot of math involved, but apparently there was. So that's the calculation there. And then key to this is set up a good general ledger. If you know ahead of time what's not allowable and what is allowable, and set those up in separate accounts and code your invoices as they come through the year, makes things a whole lot simpler for whoever's preparing your cost report and for you to get that information. So here's some of the things that you'll want to keep up with as far as non-RHC services. And again, set up these cost centers in your trial balance. That would be great. If you're provider-based, the forms don't exactly look the same. They're actually less to them than the independent RHCs. There's the same concept still applies. This is your green area. This is actually your yellow area down here. And a lot of the stuff gets actually allocated through the hospital cost report for you guys. And then your red section is right here. This line's 23, 24, 25, 26. So it's a lot less detail than the actual independent RHC. And then for you guys, you do have this is your B-1 statistics there. These are the statistics I said before. You really need to keep up with your square footage and how you use that square footage, do some time studies, gross salaries, accumulated costs. These are ways that you allocate cost and put those in the right area if you're a provider-based rural health clinic. One thing that you should be doing is benchmarking your cost reports. This will tell you when things go sort of awry on you. And so very helpful here, like provider-based RHCs here, you can see WIFLE, the National Association of Rural Health Clinics. If you're a member of that, which I highly recommend that you join, you can get a free benchmarking report from WIFLE. In this case here, we had a parent provider allocated overhead. You just want to see if you got a reasonable amount of overhead per visit allocated to your rural health clinic. In this case here, our clinic had $122.44, which is high compared to the national average of $78.20. per visit. So you'll want to, this will be very helpful to know if our number was really low, and I've seen some clinics where they were only allocating $30 or $40 per visit, and we knew that there was something wrong with their statistics when they do that. Same thing if it's an independent RHC. I know the one cost report we were working on today, or a couple of days ago, looking at reopening, I was seeing physicians seeing, 9,000 or 10,000 visits, and our nurse practitioners and PA seeing 8,000 or 9,000 visits, and the benchmarking report would tell us very quickly that you're way, way above the national averages for number of visits by provider. We may be double counting our T1015s or miscounting our visits on the cost report. So highly recommend doing this benchmarking, so it's going to help you with your cost report. Okay, healthcare provider FTEs. One of the things is there's something called productivity standards. We want to keep good records on our providers, how much time they're working, because there's a productivity standard that for a physician working full-time, 52 hours a week, 2,080 hours a year, they should be seeing 4,200 visits. That's about 16, 17 visits a day if you count 250 working days. So a physician, to do the bare minimum to meet productivity standards, they got to be seeing 16, 17 visits a day. For a PA or nurse practitioner, you put that number in half, it's 2,100 visits. So they need to be seeing about 7.5 to 8 visits a day to meet minimum productivity as a rural health clinic. Now, the reality is if you want to pay your bills, a physician probably needs to be seeing between 25 and 30 visits a day, and the nurse practitioner and PA probably needs to be seeing probably 15 to 20 per day in order just to pay all the bills that you have to, as far as a minimum productivity for that. So what you'll want to do is do time studies on your providers and see how much time they're actually working, because we want to make their FTE, just like we want our visits to be as low as possible, our productivity standard, we want it to be as low as we can reasonably get it to be as well. So in this case here, we want to do a time study. Here's some, I know this is not your MAC, but WPS has some information about how to do time studies. The time study rules are all over the place. It's the MACs have different rules for that. What the Medicare rules say is you're supposed to do one time study a month for 1 week every month. That's sort of ridiculous for physicians, nurse practitioners, and PAs to be spending that much time on paperwork. I've seen some of the MACs say we could do 1 a quarter. I think the WPS said maybe 2 weeks a quarter you could do. So you'll want to try to keep up with the time. This is a form from David James with National North American Health Management Services that he uses, and then Julie Quinn has this form from HSA that they use, and we basically just copied their form and stuck it in here for you because both of them are really good. So you'll want to do some type of time study for your physicians, nurse practitioners, and PAs, so we can lower that productivity standard. So here's what it looks like on the cost report. In this particular clinic, we had 1.52 nurse practitioners. They saw 5,100 visits, but here's our productivity standard, 2,100. We multiply that 2,100 by 1.52. And that gets us up to 3,192 as our productivity standard. But because our visits were more, the productivity standard didn't hurt us, and we counted 5,109. If our total visits were, in this case, maybe we only saw 2,500 visits, then we would have used 3,192 over here as our number. So we were going to use the higher of these two numbers here, either total visits or your productivity screen. And what happens to your cost per visit? If we raise that number, our cost per visit actually goes down. So that's why Medicare is wanting you to be productive. So one thing is good is productivity standards are counted in aggregate. What that means is if I am the doctor and I'm slow as Christmas and I see only 1,000 visits, and Danae is a great nurse practitioner and she is busy as she can be and she sees 6,300, we have met the productivity standards in aggregate. So a high-performing provider can pull up by the bootstrings one of your lower performing providers. So that's good. Also, because of the pandemic, you can get waivers now for this. In the past, you could get them, but they were very hard to get. Now they are very easy. Novitas is great about responding to these and giving you waivers. Sometimes they don't give you all that you want, but they're very good about processing these waivers. And if you have a productivity standard, you will want to do that because it's going to help you. And the chances are very good that you're going to get it. COVID vaccine changes for 2022. Weird thing was in 2021, we were putting advantage patients for COVID vaccines and MABs because Medicare did not have a system to account for that at the time. Going from now on, 2022, you do not put advantage patients for COVID vaccines or MABs on your cost report. It's back to the way it always was, which it always was. Original Medicare, red, white, and blue Medicare is the only things you put on the cost report. And what happens is Medicare will reimburse you additional money for flu and pneumococcal. So pneumococcal rates, I got the rates here somewhere. I'll show you what the rates are just in a second. But you'll want to keep your total flu and pneumococcal shots. You need to get that number. You also want to get the original Medicare number. And for your original Medicare, we're going to have a log where we show the patient name, the MBI number, and the date of service. Okay, and so you want to keep up with your cost of supplies. You'll want to have that general ledger account. Whenever you go from Merck or whoever you're buying your flu and pneumococcal from, keep those invoices and put those in that separate cost center so we capture that cost. Also, make a copy of that invoice and send that to your cost report preparer because Medicare is going to ask for that. If you don't keep time records on how long it takes you to do these, we normally use either 10 or 15 minutes for your flu and pneumococcal shots for that. So here's what we would ask for when we're doing a cost report for influenza and pneumococcal. Here's what your log would look like. Again, very simple. MBI number, date of service, patient name. Simple as it can be. For influenza, what we're seeing as far as the benchmark goes is about $66 for an influenza shot and about $270 for a pneumo shot. Now, it will depend on your ratio of Prevnar 23 and Prevnar 13. I think there's a new Prevnar type of shot that's come out too, which I don't know what the cost of that is yet. But depending on what that ratio is, it could be higher or lower. They don't have separate places on the cost report for Prevnar 13 and 23. It's all lumped together. So I wish that wasn't that way, but that's the way it is. Okay, so now I've got a little nasty note here telling me that I've used up my 50 minutes that I promised I would limit myself to. So let's get through this particular section and then we'll cut it off and answer some questions here. But let's get through this section. Here's what you should have logs, and I just put the pneumococcal log. The flu log will be exactly the same: COVID-19 or MABs, patient name, MBI number, and the date. And then what I like to do is put a page number on here, the total per page, and then the total Medicare, and just keep a running total for this, and that will make it so much easier for us to count. Okay, I stopped at a pretty good place here on Medicare bad debts. That's where we'll pick up next week, and I will pick up with some advanced cost report subjects. We'll talk more about CAA and about how to keep your cost up next week as well. But this is a good stopping point for us today. So Danae, if we have questions or want to open up the line for people, that would be great.
Yeah, so if you do have any questions, you can pop them into the Q&A box. We have one here, I think is more of a statement than a question, but you can, give any comments that you have to it. So the note here is allowable rent. If there's 3 owners of an RHC and each owns 33% of that RHC, one of those owners is 100% owner of the building. It's allowable since the building owner is only 33% of the RHC and he's not the medical director.
Yeah, well, yeah. What they're asking about, is that a related party? And the answer is yes, absolutely, it is a related party. So the way the Medicare rules work, and we'll talk about this next week, but the way the rules work is whatever that rent is, we pay $100,000 in rent to the three owners. That $100,000 is going to be disallowed because they have control of both sides of that transaction financially. So we're going to disallow $100,000, but what we're going to do is we're going to put back in how much did they pay in mortgage interest, how much did they pay in property taxes, repairs, whatever it is. So we're going to put your actual cost back in. So if they had $60,000 worth of actual cost, we'll put back in the $60,000 as allowable, and we will net end up disallowing $40,000 of the expense. But it is definitely going to be a related party transaction. I know I had that same exact situation happen to me when I was a owner of a building, and we had partners like that, and Medicare considered it to be a related party. So I know it was a painful experience, painful personal experience on that one. So, okay, any other questions?
I don't see any other in the Q&A box right now, so I'll just give it another minute in case anybody's typing.
Okay, all right, good deal. And then I will today I will send you a new slide presentation, because when I was practicing, I noticed a couple of things I changed from the version I sent you earlier in the morning. So I will send you a new version of it if you don't mind. So
not a problem.
Okay, yeah. My Tennessee grammar was a little bad in a couple places. Okay.
All right, not seeing any questions. Mark, do you have any last minute words of wisdom to impart before we wrap up for today?
Let me see. I tell you what, one thing let me see, just because we have a little bit of time, I want to go through and just remind people, where is it? At the very end. Yes, there's all that stuff here. Here we go. Because we're at the end of the fiscal year, if you guys are a 12/31 year end, and you want to claim Medicare bad debts, you'll want to write those off by the end of the year. So if you think you have bad debts, let us know, and we'll tell you how to do that. You want to also PRF reporting deadline. If you've got any of that phase 3, phase 4 money, that's for period 4. Your deadline to spend that money is 12/31 of this year. So keep that in mind. If you do use it for lost revenues, that's fine for PRF reporting, but do remember that you could use this money to pay hazard pay, retention bonuses, that sort of thing to your employees, and that would be an allowable expense on your cost report. So you'd actually get an extra benefit of increasing your cost per visit and getting more money from Medicare if you did that. So you want to think about using that money by the end of the year. Just look at spend your money as much as possible, because you are coming up on that deadline as well. So that's just some reminders, because December is a busy month for everybody as far as cost report. You got cost reports you have to deal with. Let's see the slide before this. I think it's, you want to meet with your tax accountant, your cost report preparer, and your PRF fund advisor, because a lot of times we don't give the same advice because we come from different places. But okay. And then do we get another question that come in while
we did? So related to the bad debt, is that a Medicare red, white, and blue only, or Advantage plans as well?
Good question. It's just for Medicare original red, white, and blue, unfortunately. So yeah. And just to give you a real quick before we leave, it's just for copays and deductibles that you bill on a UBO4 is all that it is. So if sorry Mark Lynn doesn't pay that $233 deductible at the beginning of the year, and you try to collect for at least 120 days from date of first bill, you send me 3 or 4 statements and I don't respond, and you turn me over to collection agency, and the collection agency doesn't get it, and you take the account back from the collection agency, and and write it off of your books, write it off by the end of the year, then you can put that on the cost report, and that $233 will turn into 65% of that. So whatever, 65% of 233, Medicare will actually directly pay you for that. So what if the patient is deceased? Yeah, if you stop trying to collect the money from them and write that off. It's based upon the date that you write off the account, not the actual date of service. You can go back, as if you've been a Royal Clinic for 15 years, you could in theory go back 15 years and write off anything. Of course, you have to get the information. Again, next week we'll show you the 10 columns of information that you need to put in there. So you're not gonna be able to go back 15 years, but I'm just, that's if you got the information, you can go back and get that. You just got to write it off in that year. Okay. Any other questions before we get out of here? Yeah, Danae, I think that's the last of them. I've got to get to my North Carolina Medicaid meeting now.
All right. Well, thank you so much, Mark, and thanks everyone for joining us. As a reminder, please complete the brief survey. When you exit, it should automatically pop up in your browser. The recording of this webinar will be on our website within the next couple of days, and we hope to see you next week for the more advanced 201 webinar at noon on the 15th. So as always, please feel free to reach out to us at LRHA if we can be of any assistance, and thank you and have a wonderful day.
Yeah. Thank you. Bye, everybody.